Welcome back. Continuing on the atypical Parkinsonian syndromes, a clinical approach. This is part 2, section B, the third segment of the atypical Parkinsonian syndromes. I'm Partha, a neurologist, a national professor of neurology of India, and presently working for the National Health Service in England. This is me. I graduated from Kolkata in 1990, and from 1994, I've been pursuing my career in neurology in UK, initially in training and later on in service. I'm a member of several Indian and international neurological associations. I would like to begin my lecture on this occasion by paying my tribute to a great neurologist of India who once again was a martyr to the COVID illness. This is Professor Dr. Ashok Pangaria, who was the proud recipient of the B.C. Roy Award and Padma Shri. He developed post-COVID and passed away at the very young age of 71 on the 11th of June. I dedicate my talk to him, as I do to several COVID warriors who have been laying down their lives in the line of duty. And I also pay my respects to the countless lives that have been lost and damaged through long COVID in the COVID illnesses. We hope this misery for the human race ends very soon. I have no conflicts of interest or financial disclosures to report to you. Like I said, this is the third part. In the part 1, I covered multiple system atrophy, dementia with Lewy bodies, progressive supranuclear palsy, and corticobasal ganglionic degeneration. In the last lecture, I was dealing with vascular Parkinsonism, drug-induced Parkinsonism, toxins that cause Parkinsonism, and normal pressure hydrocephalus with chronic traumatic encephalopathy. My request to all of you, as always, is to refrain from taking videos that I'll be showing you from public forums, but nevertheless, these are of patients who have given their consent for these videos to come online for our learning and teaching. So do have the respect for their wishes and confidentiality and privacy and dignity. In this particular section, this is part 2, section B, I will be covering post-encephalitic Parkinsonism, frontotemporal dementia with Parkinsonism, Parkinsonism dementia complex restricted to Guam and Guadeloupe Islands. There is going to be the discussion of Neurodegenerative Parkinsonism, genetic Parkinsonism with the advancement of clinical genetics and next generation sequencing and newer forms of finding out the genetic basis have led us to identify the monogenic Parkinsonisms as well as Parkinsonism with associated other neurological manifestations. There is the important metabolic causes of Parkinson's disease with treatment opportunities and dopamine synthesis defects like DRD, dopamine responsive dystonias, metals, Wilson's, we cannot forget, the recently ever expanding genetic identification of NBIAs, neurodegeneration with brain iron accumulation, manganese, which we have managed to slowly root out as occupational exposure. There is this new group of infectious, post-infectious, and immune-mediated Parkinsonism, which I will be talking about, and of course the pediatrics manifestations of Parkinson's disease. We will be showing you several genetic ones. And again, I request you not to take any videos and to respect patients' dignity, privacy, and confidentiality. So let's start with the last part of the atypical Parkinson syndromes.
Now let's shift gears and talk about something historic about the post-encephalitic Parkinsonism. Now that we're in the COVID illness, about 100 years ago, something similar happened, very tragic. The encephalitis that affected and killed so many people and left so many others with a great disability. The characteristic finding was that within 10 years of infection with that virus, many developed Parkinsonism, and they had behavioral and sleep abnormalities, Parkinsonian features, oculogyric crises, and a conundrum of extrapyramidal symptoms that were there. It still happens, and we see them sporadically with patients with Japanese bee encephalitis in India, West Nile, Eastern equine encephalitis, where there's a lot of extrapyramidal symptoms. So that's the post-encephalitic, post-viral encephalitis that often results in a severe extrapyramidal syndrome. For the history, let's look at this particular picture of a post-encephalitic Parkinsonism patient. Patient actually has some thalamic dysregulation, and she falls asleep. In the middle of the examination, you will see. There's no silent era, so there's no sound. (1920s). Encouraged by the doctor to touch the nose, soon falls asleep. Von economo encephalitis. Right. So let's move on next to the next condition, which is some of the neurodegenerative and possibly genetic conditions I was going to talk to you about. Frontotemporal degeneration with Parkinsonism. Here, patients have a family history and a dementing disorder. It's a tauopathy. It starts off in the 50s and 60s with personality and behavioral changes with a lot of disinhibition, aggressiveness, and Parkinsonism. There were some regions of the world which come up with very peculiar Parkinsonism conditions and dementia complexes of Guam and Guadeloupean Parkinsonism. It's felt there might be some local toxin in those areas that might be causative, but the exact causes have not been identified so far. There is also a motor neuron disease association with the PD dementia complex in Guam and also in the Kii Peninsula of Japan. Now, shifting gears, let's talk about some heredodegenerative Parkinsonian condition. The first one I put up there is dopamine responsive dystonia, and I will let you hear the patient's account of a 33-year misdiagnosis of cerebral palsy of the dystonic type, which was dopamine responsive dystonia, Segawa disease, after Professor Segawa. There is Huntington disease, there's Wilson's disease, which we see quite a lot. There is this new group of conditions with increasing genetic diagnosis of the neurodegenerations with brain iron accumulation. I'll be detailing. There are these scars we've talked about earlier. There are other prion diseases, Lou bugs, familial brain calcification or Farr's disease. There are mitochondrial cytopathies with striatal necrosis and steroid lipofuscinosis. and neuroacanthocytosis and neuroferritinopathy. So we'll be talking about all of them. I wanted to bring this slide up just to show the field of genetic Parkinson's disease identification that has been occurring for quite some time now. And we must not be missing out on the genetic diagnosis, because the Indian Academy of Medical Genetics is quite well equipped to undertake these tests for you in various different panels once we make the association and ask for these tests in the various different individuals. We are all familiar with the synucleinopathies, alpha-synuclein, autosomal dominant, and the first gene that was detected in typical Parkinson's disease. And then we have had PARK2. I'll show you a patient of PARK2 mutation. There's also PINK mutation. I'll be showing you a DJ1 mutation. There are LARC mutations as well. Kuforakib is very well discussed in the neurological community, in the movement disorder community. There are a whole host of other PARKin mutations that are also sort of identified in lesser frequencies. So the issue about the genetic forms is that there are monogenic causes, which may be only Parkinsonian or maybe purely Parkinsonism. There are the ataxias, which have Parkinsonian components, and I'll be showing you a video of a fragile X tremor ataxia syndrome, which can be mistaken for multiple system atrophy. There is neuroacanthocytosis. There are dementias of the juvenile Huntington's type, and there are Alzheimer's type and FTD Parkinsonism we talked about. Hereditary spastic paraparesis can look often like Parkinsonism. Now, here is this particular mutation of the DJ1 mutation I was talking to you about. If you can read that as I play the video, and you can see what's happening to this patient.
Can you bring his hands like that? It's fine. Ahmed,
So,
try and hold you. With the same hand. We'll use the... And touch your nose. Very good. And touch the pen again for me.
that's a stereotype you see. It will be more in the second video.
Ahmed, try and do this. And go round and round like that.
So, Parkinsonism, dystonia in the hands,
Well done.
tongue tremor, and you saw some myoclonic jerks as well.
And again to the other side. And up to the ceiling. And down to the floor. And up to... Show me your tongue, Ahmed. And wiggle it side to side.
Tongue tremor.
Very good. Okay.
Here I was just trying to show you the stereotypy, where he suddenly presses on his eyes using both hands. Stereotypy that you see, and you can see his dystonia and the clenched sort of fists that he has, and the dystonia in the face at the same time. That's genetic Parkinsonism, DJ1 mutation you saw in the previous slide. Right, let's move on. So, yeah. Right, now this is the Parkin mutation, PARK2 mutation I was going to show you. Here's the patient with the genetic Parkinson's.
This patient with PARK2 Parkinson's disease has reasonably normal facial expression. She has some difficulty with rapid finger tapping in both hands, but it's relatively mild. She's able to get up from a chair with her arms crossed. And gait is relatively normal. Arm swing is reduced in the right upper extremity compared to the left, and pull testing is positive.
Right. So that was part 2 mutation, just giving you the features. Here's this chorea neuroacanthocytosis.
What kind of problems are you having with the chewing and the eating?
Food gets stuck on the gum and the teeth, and the teeth in the teeth, and I did it like a rattle, and it's stuck in the teeth, and broke the teeth.
Any trouble with swallowing?
Once it passes the tongue,
Once it passes the tongue.
yeah,
What kind of a diet are you having?
perfect.
What do you...
Right. In this particular video,
The patient with young onset Parkinson's disease exhibits relatively normal gait. There is reduced left-sided arm swing.
very young onset of Parkinson's disease, likely a genetic etiology, asymmetric at onset.
There is apparent facial masking, and repetitive fine finger movements and hand movements on the left are slow with some decay over time.
Hypokinesia, bradykinesia on that side. You can see the dystonia on that side, as well as the bradykinesia. Let's move on to the next series of videos. Here I have actually put together quite a few PSP
Look at my hand.
like
The other
Parkinsonism from Kuforakev,
And here
the
again.
genetic Parkinson's we talked about earlier on.
And down. Finger here. And down.
My hand,
This is actually a juvenile Huntington disease.
the camera,
You can see out here. So these are looking like progressive supranuclear palsy.
my hand.
Clearly a supranuclear gaze palsy here.
No,
Bradykinesia.
that one now?
This patient has Niemann-Pick C
To the
disease.
right. Look to the right. Straight ahead. Look up.
Again, a restriction of movement in the vertical gaze.
And up.
And this one is actually a mitochondrial mutation, POLG mutation. Mitochondrial cytopathy
All the way to
causing
the left.
a PSP-like phenotype because of the eye movement disorder
Straight
abnormalities.
All the way up. All the way up. All the way down.
Full test positive. MSA, multiple system atrophy-like features in Fragile X, tremors, ataxia syndrome. Ataxia. see the walking pattern, right? So let's move on to the metabolic disorders, which can also cause a Parkinsonian syndrome. These are the storage disorders, lysosomal and lipid storage disorders. We have Gaucher's disease, which presents with hepatosplenomegaly, and that sort of gives the diagnosis away. And they have cognitive disturbances, REM, sleep behavior disorders, a staring look, and a stimulus-sensitive myoclonus with bradykinesia. There is also the other condition, which is rare, but it's very fulfilling to diagnose, the cerebrotendinous xanthomatosis, because it's treatable. And there are features of gator imbalance, cerebellar features, and Parkinsonism. And MRI shows the characteristic features, but the tendon xanthoma is the giveaway sign one must look for, because again, it's very treatable with genodeoxyfolic acid. There are other conditions which are to do with the dopamine synthesis pathway defects, the GTP cyclohydrolase pathway, the Sigawa syndrome. I'll show you the picture later, the account of the patient later, but it's young limb onset, young patient, lower limb onset of foot dystonia, often misdiagnosed as dystonic cerebral palsy. And there are some tests, phenylalanine loading test, but the best one to use is the dopamine challenge with levodopa. And there are other conditions, again, genetically driven of dopamine receptor transport deficiency syndromes. Let's move to some metals which can cause a Parkinsonian syndrome. We're all familiar with Wilson's disease, never to miss. And there's also a genetic confirmation of that. MRI shows the Pandas sign in the basal ganglia and the brainstem. There are other conditions that we have been diagnosing since the 2002 as NBIA. And the other condition is aceruloplasminemia. There are the PCAN and MPAN, where is basically there is the pathological iron deposits in the basal ganglia, and there are genetic correlates to that. I would refer you to the brain article of Dr. Horwath, which outlines all of those. That's the list of conditions that will come up: the PCAN, the PANC2 mutation, the PLA2G6, the one that I talked about earlier, the C19ORF12 mutation, the beta propeller one. Then there is the FAHN, the Kuforake, the neuroferritinopathy, aceruloplasminemia, all to do with brain iron accumulation. The MRI will be giving you the diagnosis. So please interact with your neuroradiologist to give you the clues as to which ones these are. MRI of the basal ganglia, focus studies. This is a patient I just brought up as a representative of the NBIA disorders to show you what they look like.
This individual with neurodegeneration with brain iron accumulation displays while sitting a fairly generalized dystonia, predominantly affecting the trunk and cervical region. While walking, he displays slow involuntary movements involving his left upper extremity with flexion at the elbow and abduction at the shoulder. Gait is characterized by short stride length, some shuffling, and the associated left upper extremity movements.
Right, moving on from here, the next video, basically manganese. I was talking to you about it from the days of manganese mines, including in Madhya Pradesh. There was Dr. Neogi who did the first studies even before the Chilean video was shot, 1958. A great person who brought about the identification of the manganism in individuals who are working in the manganese mines. There are other non-occupational causes of manganism that we identify, including sort of in drug addicts and in other conditions where we must be able to identify the manganese, hopefully less with increasing sort of industrial health identification. But those are the features of manganism. I thought I'd show you, just for the historical notes, of the original footage from the Chilean miners with manganism.
Manganese poisoning occurs among 1 to 4% of miners working in the manganese mines after variable periods of time exposure. The first patient worked only 6 months when he developed a dystonia. The gait is markedly impaired with hyperextension of the feet. His arms are flexed against the chest. While he has marked difficulty for turning around. There is great difficulty to opening the hands due to simultaneous contraction of agonist and antagonist muscles, and his smile is always childish. On L-DOPA, he is able to run.
Levodopa responsive.
During gait, the hyperextension has disappeared. He is able to press the heels against the ground. Decrease sustentation base, and there are some associated movements. The arms can be lifted and the hands opened without any difficulty. The childish smile has disappeared. A second patient developed also dystonic contraction of the upper extremities with impossibility to open both hands. In particular, the left hand that has never been opened for the last 8 years. There is great rigidity and difficulty to extend the arm, and a dystonic dorsal extension of the toe is apparent during gait. On L-DOPA, the pseudo-Babinski sign disappeared. The gait improves markedly with associated movement. And the left hand can open while the right hand can be easily managed. He is also capable of complete extension of the arms. A third patient presented rigid gait. With impossibility of walking backwards, and marked impairment of postural reflexes. On L-DOPA, the gait improves. There is, for the first time in 25 years, possibility of walking backwards, and the postural reflexes have improved also. A fourth patient is characterized mainly by a great rigidity that shows during the gait. Rigidity is clearly evident on neurological examination. On L-DOPA, rigidity has disappeared with a slight hypotonus and hyperextensibility of the joints. And this reflects on an improvement of the gait and associated movements.
Right, so that was actually a historical video from 1967 of the Chilean miners showing it. I just wanted to show you another picture, another video of ladies from Thailand. Oh, this particular video was from the Chilean miners of manganese before and after levodopa treatment. You saw that the picture quality was a bit grainy because of the age. Here I want to show you some of the ladies who worked in the battery cell
เพราะฉะนั้น
factories and were exposed to
เรา
manganese
จะสังเกตได้
as
โด
part
ย
of their
อาศัย
jobs
ลักษณะการเดินนี้
and watch
เป็น
their
ลัก
sort
ษ
of
ณะ
walking. And this is
แรก
actually a
ที่จะ
very
ใช้
interesting
วัดความรุน
video
แรงของโรค
of workers who work with battery cells being exposed to manganese and the way they walk and how they were affected by it. Right, let's move here and then move on to the other category of infectious, post-infectious and immune-mediated causes of Parkinsonism. We've talked about Japanese encephalitis. I've showed you videos of the encephalitis lethargica. I just wanted to remind you of CJD. I have a video coming up next, but of neoplastic and perineoplastic causes of Parkinsonism. Now, this particular lady has HIV-induced Parkinsonism.
This woman with
Watch.
HIV-Parkinsonism displays generalized bradykinesia, very prominent facial masking, and a fixed stare. She's able to protrude her tongue, but side-to-side horizontal tongue movements are slow.
The staring look, the bradykinesia that you see out here.
Movements are markedly slow with very reduced amplitude of movement.
Some dystonia seen in the hands as well. Spooning of the hands.
There's some spooning type of dystonic posture of her hands when placed opposite each other.
Very bradykinetic. Lack of facial expression. HIV causing Parkinson's disease. Let's move on. Yes, this was a Creutzfeldt-Jakob disease. Have a look. Left-sided dystonia, rigidity, apraxia, mild clonus, and cortical sensory loss with pathologically confirmed CJD.
Okay, turn them over.
What number am I drawing in the hand now? Turn around and come back. Good. I would just salute with your right hand. Very good. How about this? Good, good. And how about that? Could you salute with your left hand?
You can see the apraxia on saluting with
Show me how you'd hold a saw and saw wood with your left hand.
being asked to demonstrate how you work a saw with the left hand. Right. We'll finish up with some notes on children's bradykinetic disorders. Of course, Wilson's comes in there at the top because it's treatable. There is Huntington disease, which will not have chorea as a presentation, but will have extrapyramidal symptoms as the presenting type, dystonia, ataxia, seizures. There'll be the condition of the neurodegeneration with brain iron accumulation. We talked about that big list we had out there, all genetic. And then we have these other conditions to consider over here. So let's look at this particular video of a child showing an oculogyric crisis. And this was because of a gene abnormality of dopamine decarboxylase gene abnormality. Just wanted to show this to you as a representation of movement disorders in children, which is an entire field in itself to consider, diagnose, often enzymatic and genetically conformable. Right, let's move on. So in summary, I've identified for you several conditions which produce Parkinsonian syndromes, which are not degenerative, are secondary, and are not idiopathic Parkinson's disease, of which Wilson's disease we must not miss. Dopamine responsive dystonia we mustn't miss. MRI will help us for identification of the NBIA categories and of the toxins. There is large number of genes being identified, and we have them available in India once we ask for the right test. And let's finish with Wilson's disease. I was looking for some Indian subjects.
This patient with Wilson's disease displays a very characteristic wing beating tremor of both upper extremities.
And let's watch this patient because the KF ring is the giveaway. Again, the wing beating tremor, as you can see, but look for the KF ring. Often in advanced cases, you'll see them in the clinical examination, although slit lamp is actually required an ophthalmological help to diagnose it. You can see the jaundice as well in the patient. There you go, the KF ring. Right. So I want to finish up with the patient's viewpoint. Here is a lady who for 33 years was diagnosed as cerebral palsy.
And for the first 33 years of my life, I thought I had spastic diplegia, a form of cerebral palsy, only to discover 3 months before my 34th birthday that I actually have dopa-responsive dystonia. And since then, I've been on the medication L-Dopa, which has drastically improved my mobility. Unfortunately, I don't have any video from, or very limited video from when I had cerebral palsy, and so I wanted to get some video of myself showing how much L-Dopa helps me. So starting tomorrow, I'm going to be reducing my medication and coming off of it slowly to show how my mobility will decline. Right now, I am on my full amount of Sentiment L-Dopa medication for dopa-responsive dystonia. I just want to get some video of me walking. Okay, so today was day 1. I did not take my L-Dopa this morning. I did take my medication at noon and then again at 4. You could tell this morning that my legs felt heavy, weak, and still this afternoon I could just feel a little bit of an achiness in my body, probably more so in my neck and shoulders and whatnot. So now we'll walk, or I'll walk.
Here the lady is off levodopa, only from that morning, day 1 this is. She's quite all right.
5. I did not take my slow release before bed last night, and I have not taken any medication today. My legs feel like jello, and they feel like they're very heavy and almost hard to carry along with me. So, let's see how I walk.
See, she's quite stiff and slow and not raising the feet off the ground.
So today is day 6. Second day not taking any L-DOPA. And let's see me walk.
She's really dragging herself.
Kind of feel like a little old lady. Okay, so today is day 7. I've been off my medication, completely off for about a total of 3 days. I'm really disappointed because I was hoping to get myself recorded in a worse state. My walking isn't as bad as it was prior to getting my new diagnosis, but I can't go longer without it because my ankle is starting to hurt, and I am concerned that if I keep going, I might injure myself, and I mean that would be kind of defeats the whole purpose. And my knees are starting to hurt, and so anyway, I'm gonna walk or try.
This is after she's been off the medicine for 5 days, she says, and you can see how much of difficulty she's experiencing when she's off the levodopa. She has been
I'll go back one more time.
Diagnosed as dystonic cerebral palsy for 33 years, and only when she was diagnosed as having dopamine responsive dystonia, she got much better. And she'll show us a video.
So I know a lot of people would wonder why I've been doing this. Why would I come off of my medication to then walk like this when I've got this medication that helps me get from point A to point B with ease?
Listen.
Simply, I'm just trying to bring awareness to dopa-responsive dystonia. There are all kinds of dystonia out there, but my particular kind is dopa-responsive dystonia. And I was misdiagnosed for 33 years, thinking I had spastic diplegia, a form of cerebral palsy. Okay, so it's been 24 hours on my L-DOPA, and obviously
now she's back on the drug.
Amazing
24 hours and perfectly normal person.
I can tell that my calves are very sore from all the spasticity, and my glutes and my...
I thank Mrs. Abbott for sharing her picture and her video to educate us doctors about this condition, which we mustn't miss. Right, so my acknowledgements are to the Spring Video Atlas series of movement disorders, the American Academy of Neurology, International Movement Disorder Society website, from where I looked at a similar presentation of Dr. Professor Kailash Bhatia, and Up to Date, and the recent edition of Neurology in Clinical Practice, which dates the vascular Parkinsonism as the second common cause of Parkinsonism. And the YouTube is a rich source of patient videos that I have managed to borrow from, and I'm very grateful to those patients who have given the permission to disclose their illnesses to us to understand. And namaskar and jai hind, and thanks for listening and giving me the time to speak to you. And hopefully you will be fine doctors to alleviate the sufferings of our Indian patients and of the ones who wish to seek your service. Long live IMA. Thank you very much. And namaskar and jai hind. And if you have any questions, you can email me